Our today's lecture is on radiotherapy for anal and rectal cancers, and our speakers are Dr. Archie Pollom and Jeff Sweeten. Brief introduction. Dr. Pollom is associate professor at Stanford and in radiation oncology and neurosurgery. She used to be a resident here and now quickly rised up to a director of clinical operations of radiation oncology department. And her specialty is GI tumors, pancreatic cancer, and radiosurgery for brain and spine tumors. This year, she's quite a superstar. She received the Kaplan Memorial Prize for Teaching and Richard Hoppe Leadership Award. She is a very prolific researcher, having around 300 publications behind her belt. We are very proud of her. And Jeff Sweeten is our amazing dosimetrist at South Bay, and he will be teaching us rectal anal cancer planning at the end of the session. But first, we'll start with the clinical lecture by Dr. Pollom. Take it away, Archie. I'll stop sharing.
Okay, great. Thank you. That was a really nice introduction, Natalia. So I have a lot of slides, but I think the plan is I will spend the first half of the lecture going through just some clinical background, and then Jeff will have the latter half. Is that correct? So I'll try to limit my portion to about 30 minutes.
45 minutes.
Oh, 45. Okay.
Yeah.
So, and then Natalia, will folks be able to access the slides after the talk?
Yes.
Okay, great. So yeah, I have a bunch of slides. I think a lot of them, I'll just fly through them, but they're there just so that you all have it for reference. And I'll mainly just focus on some highlights because there is a lot to cover for anal and rectal cancer especially because there's just been a bunch of data the past few years that has really changed the standard of care. So I'll just start with some basic anatomy and imaging. We'll be talking about the lower GI tract. So we have the colon that goes into the rectum and ends in the anal canal. If you take a closer look into the rectum and anal canal, so we think of, we divide up the rectum in three portions: the lower rectum, which includes the anal canal, so that's 0 to 5 centimeters measured from the anal verge here. The mid rectum we think of as 5 to 10 centimeters from the anal verge, and upper rectal cancers 10 to 15 centimeters. Oops, let's see. This is an important structure when we think about rectal cancers in particular. So this is the mesorectum. This, you can actually see it nicely on the MRI. So the mesorectum is basically this perirectal fatty tissue around the rectum, and it's enclosed by this mesorectal fascia. So this like thin dark line that you can see. And this is an important structure because it is removed in its entirety in a total mesorectal excision. So that is the standard surgery for resecting rectal cancers, and we'll talk about why that's important in a few slides. But the TME is basically the surgeon, dissecting along this fascial plane to have a clean dissection and, removing the mesorectum with the rectum in rectal cancer in kind of one piece. And so when we look at these images for rectal cancer, oops, why does it keep on advancing? I think it must be auto advance. Yeah, so when we look at these MRIs, we're concerned, when the tumors are approaching the mesorectal fascia. And then these are the pelvic nodes we think about. So in terms of contouring, so for rectal cancers, the nodes that are at risk that we think about are the perirectal nodes, which are in the mesorectum, the presacral, internal iliac, and obturator nodes. And for anal cancers, it's these nodes plus the external iliacs and inguinal nodes. And then just very briefly, the types of surgeries that we think about when thinking about these lower GI cancers. So a low anterior resection is basically for the rectal cancers that are a little higher up, where the surgeon is able to remove the cancer and reconnect the patient. Whereas an abdominal perineal resection, or APR, is for the more distal tumors where the surgeon isn't able to reconnect the patient. So like, for example, tumors in the lower rectum or anal canal, then the patient has a permanent ostomy. So let's start with anal cancer. This is a very rare cancer. So you can see only 1 to 2% of digestive tract tumors. Patients with anal cancers will often present with bleeding, maybe an anal mass or ulcer, itching. These anal cancers are less likely to spread distantly. Most, when they do spread, will mainly be local regional spread to the nodes. These are the risk factors for anal cancer. Workup, so exam, digital rectal exam. A gyne exam is important for anal squamous cell carcinomas because just to rule out concurrent, HPV-associated cancers, and then anoscopy, biopsy, and systemic staging. This is this AJCC 8th edition staging for anal cancer. I just want to point out the main update with the staging is the nodal staging is N1A to N1C. Previously, it was N1 to N3. And then in terms of the treatment, so just know previously these were treated with surgery. So an APR surgery, like I showed on the previous slides, in patients would have a permanent ostomy. But then in the 80s, Dr. Nigro found that in patients who received chemoradiation prior to APR, the majority of these patients had a complete response of their tumor to just radiation and chemo alone. And so that's led to our current standard of care for anal cancer, which is to treat these patients with chemoradiation alone, and most of them will not need surgery. So the radiation is pelvic IMRT, anywhere from like 50 to about, 60 gray. And the concurrent chemo is 5-FU or Xeloda. And sorry, I'm not sure why this keeps on auto advancing, and mitomycin. And then these are just kind of the dose levels from RTOG 0529, where they have, for the smaller tumors, the primary going to 50.4, and larger tumors are no positive, primary going to 54. Sometimes if it's a T4, you can try to push for 59.4 if you're able to meet your OAR constraints. And then the nodal elective nodal coverage is 42 for the earlier stage cancers, and then 45 for the higher stage. But there's different dose regimens that you can use, but this is kind of a good example. And then this trial was actually looking at IMRT, using IMRT for treating anal cancers and comparing the toxicity rates to historic controls using 3D. And this trial showed that IMRT uniformly improved all of these toxicities. So heme, GI, derm, and there was fewer treatment breaks with IMRT, which we know is important because treatment breaks are associated with poorer outcomes. And so IMRT is really the standard of care for treating anal cancers. This is another nice study that I won't go into, but is included for your reference, just showing the importance of, reducing dose to these OARs in the pelvis because they are correlated with clinical toxicity. And so these are the toxicities that we commonly see with chemoradiation for anal cancer. Acutely, dermatitis is probably the main issue. The skin around the anal area can get pretty raw, similarly in the groin because we're treating the inguinal nodes. Patients can get myelosuppressed from the chemo, diarrhea from both the radiation and the chemo, which also kind of exacerbates their skin issues. So these are things that need to be carefully managed so that patients can get through the whole radiation with minimal breaks. And then these are just some of the late side effects of pelvic radiation. Anal rectal dysfunction is something to watch out about and really limits our dose to, the anal canal. Just note in one of these trials, 5% of patients actually ended up needing to have a surgery and a colostomy because they had treatment-related late side effects, including anal rectal dysfunction. So this is something we want to minimize. And then some of these other side effects with pelvic radiation. So small bowel obstruction, hip fracture, sexual dysfunction, infertility, vaginal stenosis. And then after treatment, it's just important to be aware that it can take a while for some of these tumors to completely resolve. So in the ACT-2 trial, you can see that there were patients, 11 weeks out, 18 weeks out of chemoradiation where they still had residual tumor, but then by 6 months after chemoradiation start, their tumors finally resolved. So as long as when we're following these patients, as long as the tumor is kind of going in the right direction and responding, even if there is residual tumor, I tell my patients, we continue to follow. It doesn't mean the radiation didn't work. We don't rush them off to surgery or even biopsy, but we like to give them time for the tumor to respond after the radiation. And then just for kind of future directions for anal cancer, there's been a lot of research into de-escalating the radiation for anal cancer to minimize some of those toxicities I just talked about. And so this is the Plato trial, where it's using much lower radiation doses for the earlier stage cancers, as you can see here. And then the ECOG decrease trial, which similarly for early stage anal cancer, so T1, T2, and 0, which should have pretty good outcomes with chemoradiation, they're looking into de-escalating the treatment, so using lower radiation dose to try to minimize toxicity. And then so that's for kind of the earlier stage anal cancers. For the more advanced stage anal cancers, we're trying to improve our outcomes. So this is another trial to be aware of. It's an ECOG trial that I think recently closed, so we're waiting for the results of this, but basically randomizing patients who finished chemoradiation for anal cancer to adjuvant immunotherapy versus observation. So standardly, these patients don't get any adjuvant therapy after chemoradiation. Okay, so that takes us to the first poll question. What chemotherapy should be given concurrently with radiation for the treatment of anal cancer? Okay, yes, great. 5-FU mitomycin is the correct answer there. Okay, and then poll question number 2, compared to historic controls, IMRT improved which of the following toxicities for the treatment of anal cancer? And this is on that RTOG study that I showed earlier. Okay, great. Yep, answer is all of the above. Okay, so let's move on to rectal cancer now. So this is going to be most of my talk. And I'm going to be focusing on locally advanced rectal cancer because that's where radiation plays a role. But just some epidemiology. So colorectal cancer is much more common than anal cancer. So you can see it's, in the top 3 cancers for males and females. Rectal cancer is probably half the incidence of colon cancers. This is the staging. So in terms of workup for these patients, everyone gets a colonoscopy and biopsy. Colonoscopy is important because 5% of patients will actually have synchronous lesions where they'll have lesions in other parts of the colon or rectum. These patients all should get a CT chest. These rectal cancers tend to go to the lungs as well as liver. And then all patients should have a pelvic MRI for the most accurate local regional staging. And then this is the staging. So mainly the patients we see will have T3 or T4 disease or node positive disease, because those are the patients in which we do neoadjuvant therapy. So with the treatment of rectal cancer, we've come a long way. In the past, previously, these cancers tended to have a very high risk of local regional recurrence, so 30% in the 80s. And this was a big problem because local recurrences in the pelvis are very hard to manage. There's not a lot of space in the pelvis for, surgical maneuvering, and there's a lot of nerves, vessels in the pelvis. So recurrences can be very morbid and fatal. And so we've improved upon this number a lot. So now with current trimodality therapy for locally advanced rectal cancer, we've gotten this recurrence rate to 5 to 10% at present. And improvement in surgery has definitely contributed to this. So, I was talking about the total mesorectal excision previously. Before this surgical approach, the tumors would be removed bluntly. And, here's just an example of this. And so it's not the cleanest operation. Whereas with the total mesorectal excision, it's a very clean dissection along the mesorectal fascia so that you kind of take the rectum as well as that whole compartment around the rectum intact. And so with this TME surgery, that alone reduced the local recurrences. And then there were several studies and that led to the NIH consensus statement in the 90s that showed a benefit of adding chemotherapy and radiation to the treatment of patients with stage 2 and 3 rectal cancer, showing that the addition of these treatments improve local control and survival. And then the German rectal trial kind of summarized all of this and was the basis for the standard of care for the treatment of rectal cancer for a long time until recently. So this trial randomized patients with T3 or T4 or node positive rectal cancers and randomized them to getting chemoradiation before TME or chemoradiation after TME. And these are the results. Basically, preoperative chemoradiation was better in terms of local control, acute and late toxicity. And then the other thing to note is as you would expect, doing the radiation and chemotherapy before surgery was able to shrink the tumor enough to allow some patients who the surgeons would require that APR surgery with the permanent ostomy to having a surgery where they were able to reconnect the patients and basically preserve their sphincters. So this was the basis for the US standard of care for locally advanced rectal cancer, basically chemoradiation, TME, and then patients would get adjuvant chemotherapy. But the thing to note is, with this trial and all of these kind of advances in the treatment, we were able to get the local recurrence rates really low, but distant metastasis risk still remained high for rectal cancer, so 25%. And so there have been a lot of work in terms of how can we better control distant disease. And one of the approaches has been with intensification of systemic therapy with total neoadjuvant therapy. So giving the chemo prior to surgery. And then at the same time, there's been kind of a de-escalation of local regional therapy. So, our local control outcomes are so good. What can we do to make the local regional treatment more tolerable with less impact on quality of life, less side effects? So a lot of interest in looking at omitting surgery or omitting radiation, and we'll talk about both of those today. So first, in terms of total neoadjuvant therapy, this is basically giving all the chemotherapy prior to surgery. There's a lot of reasons why we think this is better. So it improves compliance. Patients may be better able to get through chemo when they're not recovering from a big rectal surgery. It allows us to address micrometastasis early. There's some practical reasons like reducing the time to loop ileostomy takedown. So after chemoradiation, even patients who have an LAR surgery where they are able to be reconnected, they'll still have an ileostomy for rather than being immediately reconnected, they'll have an ileostomy, and that's to give kind of their bowels some rest after the radiation and minimize issues of like leakage and anastomotic leakage. And so they're not going to be able to be reconnected until they're done with all of their adjuvant chemotherapy. So if they've received their chemotherapy all before the surgery, then they're able to be reconnected sooner, which has implications on their quality of life. And then finally, giving all of the treatment prior to surgery can enhance the tumor response, which may allow patients to not have to undergo surgery. And so this is just the current NRG trial platform of TNT. All the patients will receive TNT prior to surgery. And then in terms of the sequencing here, it gives the chemo and then the chemoradiation and then surgery. These are just some recent TNT trials that were presented at ASCO and have been published that you all should be aware of. So I'll go through two of them in this slide. One is the PRODIGE 23, which compared to your standard, German rectal trial regimen of chemoradiation followed by surgery and then chemo. The experimental arm was total neoadjuvant therapy with chemo first, followed by long course chemoradiation, followed by surgery. So kind of like the NRG sequencing that I just showed. And this trial found that the experimental arm, the TNT arm, had better disease-free and distant metastasis-free survival than the standard arm. And then the path CR was significantly higher, so almost 30% compared to 12% with the standard arm. Similarly, Rapido also looked at comparing a TNT regimen with your standard chemoradiation prior to surgery, except this TNT regimen had short course radiation first, so like a week of radiation rather than your long course 5 to 6 weeks of radiation. So short course radiation, then chemo, then surgery. And similarly, it also found improved disease-free and distant metastasis-free survival with TNT and improved path CR rates, so almost identical to PRODIGE 23 TNT. And then just a note on the chemo that was used on PRODIGE 23. So it intensified the chemo by adding irinotecan. So typically with rectal cancers, the chemo is doublet chemotherapy, FOLFOX, which is this 5-FU leucovorin combination with oxaliplatin. FOLFOXIRI is that plus irinotecan. So it's triplet chemo. And this is kind of extrapolating through some of the data with metastatic colorectal cancer where there's better outcomes with triplet chemo than doublet chemo. So PRODIGE 23 was intensifying systemic therapy in that way. And then, so you may have the question, what's the difference between short course and long course radiation? Why did PRODIGE 23 use long course? Why did Rapido use short course? How do you interpret this? So just some background in terms of short course versus long course. These are some of the earlier studies using short course radiation. So this is the Swedish rectal cancer trial, which was the only trial I think that showed improved survival with neoadjuvant radiation prior to surgery. All patients received, a week, 25 gram 5 fraction of radiation 1 week before surgery. The thing to note is these surgeries, this was prior to TME. So these patients, presumably had just blunt dissections. And so the question is, well, was there improved survival because the radiation was making up for inferior quality surgery? This is a Dutch study that was done with TME. So all patients had TME on this study, and then they looked at, whether short course, again, given a week before surgery, improved outcomes. And this study showed that the addition of radiation improved local control, but not survival for these patients. So showing the benefit of preoperative short course radiation. And so there have also been some studies comparing short course versus long course chemoradiation. So Polish 1 trial and then this TROG study. So again, these studies looked at short course with surgery a week later compared to long course chemoradiation with surgery 4 to 6 weeks later. And no difference in outcomes between local control, distant progression, overall survival, or late toxicity. As you can expect, there was less acute toxicity with just 1 week of radiation than like the 5 weeks of radiation. And then, as you can also expect, there was less downstaging with short course because these patients were going to surgery basically right away after the radiation. So very few had path complete response, so 1%. And then the patients that went to surgery like 4 to 6 weeks after long course, you know, they had more time to respond to the radiation. So their path CR rates was 15 to 17%. There was a concern with these earlier studies that perhaps there are more local failures with short course for the more distal tumors. That came out in the subset analysis on the TROG trial. But there have been some other studies where instead of surgery being performed immediately after short course, patients would get basically chemo after the short course. And so they compared, you know, short course followed by chemo versus long course chemoradiation. This was the Polish 2 trial. And now you see that the path CR rates on both arms are comparable. And a lot of these patients had those low tumors, bulky tumors, and they found no difference in terms of outcomes. So the local control was not inferior with short course. So the thought here is, well, short course with chemo and kind of similar delay to surgery, maybe it's just as good as long course chemoradiation. I also included the Stockholm 3 trial where patients still had that delay after short course to surgery, but no chemo during that delay, and found similar rates of path CR. This Stockholm trial also had a short course with immediate surgery arm and found that short course with delay to surgery had fewer post-operative complications than short course with immediate surgery. And then, of course, you have the results of the Rapido trial. So a lot of this data is suggesting if you do short course, you know, you should not do surgery immediately after the radiation. You should have some delay, and during that delay, ideally be giving patients chemotherapy. This is just to be aware of. There is a concern for increased local regional failures with short course, even with this approach. So the 5-year follow-up of the Rapido trial, the local regional recurrence rates were a little higher in the short course radiation arm compared to the standard long course chemoradiation arm, so 10 to 6%. These are the risk factors for local regional recurrence. And I just wanted to highlight this positive circumferential resection margin was a risk factor. And this was more common in the short course radiation arm. So that kind of begs the question, was it really the short course dose that was responsible for higher rates of local regional failures, or was it because short course had more breached mesorectum? And was this because there was like a longer delay to surgery from short course? The other thing is there was no assessments that were clearly done during the kind of waiting period between short course and surgery. Typically here at Stanford, if we do short course and then give them 4 months of chemo, we'll do like a midway restaging exams halfway through chemo just to make sure they're responding. And if they're not, you know, they should go to surgery right away. Okay, so poll question number 3. Total neoadjuvant therapy has been shown to improve all of the following except... Okay, so I included this question because TNT has been shown compared to, you know, standard long course chemoradiation followed by immediate surgery. TNT has been shown to improve path CR rates, distant metastasis, and disease-free survival. What it has not been shown to improve is overall survival. And so that's a controversial point because a lot of places are adopting TNT as the standard approach for treating rectal cancers, even though it has not been shown to improve overall survival. And so just to follow up on this better path CR rates with TNT, so this is something we now commonly see in the TNT era. So here's a MRI and scope of a rectal cancer. They have chemoradiation, and let's say they also had, chemotherapy prior to surgery, so TNT. And this is their post-treatment imaging and post-treatment scope. So basically that tumor has gone away completely, and this is a clinical complete response. So the question is, do you have to do surgery in these patients? And it's an important question because surgery can be very morbid. You can see there's wound complications, impact on sexual function, urinary function. Like I mentioned previously, you can have anastomotic leaks, you can have strictures, and it's not an insignificant mortality risk with surgery. And also for the patients who have to have APRs, where they have a permanent ostomy, studies have shown they have, worse body image, less sexual enjoyment, 1 year after surgery. And then even the patients who don't have to have an APR, if they're able to have an LAR, many of them have bowel dysfunction. So there's a syndrome specifically called low anterior resection syndrome, which encompasses, it's like clustering stools, soiling, fecal incontinence. So it can be very disruptive. And so we know that the patients who have a complete response to chemoradiation have better outcomes. So you can see red here is the patients who have a path CR, and they have significantly better local control, distant metastasis-free survival, disease-free, and overall survival. And so the question is, can these patients represent, a favorable cohort in which we can omit surgery? And so the Brazilians were among the first to publish this experience of omitting surgery for patients who have a complete response. So this is one of their first studies, almost 300 patients treated with long course chemoradiation. And they had surgery if they had residual tumor, but they were observed if they had a clinical complete response. And you can see the outcomes are very good here with omitting surgery for the patients who have a clinical complete response. Since then, there have been a bunch of studies, retrospective, prospective cohort studies of watch and wait. Most of them don't have as great of local control rates as the Brazilian study, but all very good. This is just one of the larger studies I wanted to highlight. This was an international watch and wait database of almost 900 patients treated at a bunch of different centers in 15 countries. And you can see they all received a very heterogeneous, neoadjuvant therapy, some with chemoradiation, brachytherapy, different combinations of chemo and radiation. But the key is all of these patients had a clinical complete response and were watched rather than go to surgery. The 2-year local regrowth rate was 25%. So this is pretty consistent with other studies. If patients don't have surgery, about 25-30% of them will develop a regrowth in the first couple of years, but the majority of these regrowths can be successfully salvaged with a TME at that point. And then the other thing to note is the distant metastasis rate was higher in those with regrowth, but it's not clear if it's because of the regrowth, like would you have been able to modify this risk with surgery, or if it's just bad biology. So, those more aggressive tumors are the ones that tend to regrow and the ones that metastasize. So then it doesn't really matter. It's like surgery would not have kind of altered this disease course. But overall, the overall survival and disease-free survival is very good. And then this is a modeling study based on that previous study, basically showing that recurrences are most likely to happen in the first 2 years. And if patients are able to make it out beyond the first couple of years without having a local regrowth, then the likelihood of them recurring is very low. And so this is why if you do watch and wait, the surveillance protocol is very important. You have to watch patients very closely during those first 2 or 3 years with MRI of the pelvis, flex sig every 3 to 6 months to make sure you don't lose the opportunity for a curative surgery if patients do regrow. And then this is the other study I wanted to highlight that was presented and published recently. So this is the Oprah study where everyone received TNT on this arm on the study with long course chemoradiation. the question that the study was looking at is the sequence of the treatment. So, you know, with the previous studies, we looked at radiation first, followed by chemo on the Rapido study. And then we also looked at the NRG sequencing, which is chemo first and then chemoradiation. So this compared chemoradiation first, followed by chemo, or chemo first, followed by chemoradiation. And the patients who had a complete clinical response would be managed with watch and wait. The patients that had residual disease, which would have surgery. I'm just going to skip through this. Oh, and so this is the results. So because it's TNT on both arms, the disease-free, distant metastasis-free survival were similar. And the main thing that was significant on this study is that the organ preservation rates was significantly higher with the chemoradiation first. And so that makes sense because with the chemoradiation first, you have a longer time before assessment for the tumor to respond to the radiation and for patients to, you know, achieve a clinical complete response. This is another study that similarly looked at sequencing. So looking at giving the chemo first or the chemoradiation first, and similarly found better response rates with the chemoradiation first and better compliance with chemoradiation first. And so that's kind of informed how we've argued at our tumor boards at Stanford. If, you know, if we have the choice, we prefer chemoradiation earlier rather than later in the TNT sequencing, so patients can kind of achieve maximum response to neoadjuvant therapy. Okay, so poll question number 4. What was the PAT-CR rates with the TNT experimental arm on the Prodige and Rapido trials? Yep, great, 30%, so 28%. And then poll question number 5. What was the 3-year organ preservation rate on the chemoradiation first arm of the OPERA trial? So the winning arm for this. It was actually 60%. So I think 59%. It's pretty remarkable. So that's, you know, basically saying in these patients with locally advanced rectal cancer, 60% are able to avoid surgery and basically have been treated, you know, successfully with radiation and chemotherapy alone. So it sets the bar pretty high for any kind of non-operative management studies. And then I just want to conclude. I just have 5 minutes, so I'll just end on some efforts to de-escalate radiotherapy. So that was kind of all of the studies trying to de-escalate surgery. There's also been a lot of interest in de-escalating radiotherapy and the side effects associated with radiotherapy. So this is the study on the Dutch TME short course study I showed. You can see that the radiation arm had significantly more incontinence and symptoms, and then 14% of these patients who had pelvic radiation had secondary malignancies. And so this was, you know, this prompted the Prospect trial, was led by MSK, which basically randomized patients to your standard treatment of chemoradiation, TME, and then post-op chemo versus just chemo alone. And if they had a good response, a more than 20% response, they would go to surgery without radiation. If they were a poor responder, then they would get chemoradiation and then surgery. And so this was published this year recently, which showed that this approach of selective chemoradiation, of just doing the chemo, was not inferior. And you can see very similar disease-free survival, overall survival, local recurrence curves. The key points for this study, though, is that the inclusion criteria was very narrow. So these were all pretty favorable rectal cancers. So T1 to T3, less than 4 nodes. So these are N1. And these tended to be higher tumors, because one of the inclusion criteria is that these patients have to be eligible for sphincter sparing surgery. So they have to be more proximal tumors. And we know that more proximal tumors have better outcomes. And so the local recurrence rates was very low in both arms, less than 2%. So just reflecting that these are very favorable patients. Also was interesting on this trial, so only 6% of patients on the FOLFOX arm needed consolidative preoperative chemoradiation. So the majority of patients responded to FOLFOX. So FOLFOX chemotherapy is very, very effective in terms of tumor response, in that. And 22% of these patients that were treated with FOLFOX alone had a path CR. So, just kind of comparing what we were discussing previously with the TNT path CR rates when radiation was included, that was like 28%. So with the chemotherapy alone, it was 22% path CR. So very, very high. The toxicity profiles were different, though. So I think more toxicity with the chemotherapy arm, with the exception of diarrhea compared to chemoradiation. But some improvements in some of the patient-reported metrics, such as bowel function and sexual function, in the chemotherapy arm. And so I think the bottom line is, this supports, it's like it fits with all of our efforts to de-escalate trimodality therapy. I think a lot of patients with the more favorable risk rectal cancer, they don't need all 3, treatments in terms of surgery, radiation, and chemotherapy. But the question is, which one should you de-escalate? Would you remove the surgery, or would you remove the radiation? If you're trying to remove the surgery, radiation, I would say, is critical in terms of trying to avoid the surgery. And so I think this just makes the discussions with our patients a lot more interesting in terms of, counseling them on the different side effect profiles of all the treatments. So like in younger female patients, maybe they're more motivated to avoid pelvic radiation, or patients who already have neuropathy, or, kind of issues with that may be more inclined to avoid, oxaliplatin chemotherapy. Patients may have a preference in terms of whether they want to try to avoid surgery versus radiation. So I think these are all things to keep in mind in terms of interpreting that study. So that was basically it in terms of the background. Just very briefly before I hand it over to Jeff. So with our simulation and treatments, for my rectal cancer, I've been simming and treating them prone on the belly board and getting IMRT if I have auth for it. If I'm covering the inguinals, then I'll sim them supine. And then this is just, data supporting IMRT. I'm extrapolating from the anal IMRT data that I showed earlier. There's also some data in GYN showing that IMRT has less toxicity than 3D. And then just some data showing the best small bowel doses comes with prone IMRT. And then I'll just skip over this on treatment management for the sake of time, but this is all kind of included in the slides. And then one more thing is for the younger patients. So patients younger than 40, I will refer them to our gyne oncologist to do ovarian transposition. So basically kind of here, you can see the ovary in yellow. They'll go in, it's a laparoscopic procedure, very fast recovery. They'll just move the ovary out of the field. They'll clip it so that we can delineate it. And you can see that that way it doesn't get any radiation and patients don't have to go through premature menopause.